Learn pathology, a little bit of a refresher from last lecture. So we got this papilloma here. What do we think? Is it benign or malignant? Benign, right? So remember I told you that OMA most of the time is benign. There can be some unique circumstances where OMA does not mean benign, but for the most part, if you see something with OMA that's variant, means benign. Okay? Alright, so which one of these is characteristic, which is not characteristic of malignant neoplasm? Neoplasm, if I can speak. Right, so think about malignant neoplasms, they're going to proliferate pretty quickly, they're going to rapidly try to divide, so they're going to have a lot of mitosis, and it's not going to be rare, they're going to be rapidly proliferating, and then that's how they're going to eventually break away and go elsewhere in the body. So the process of determining the cancer severity is based on tumor size and spread within the body. This is known as what? All right. I'm hearing some right answers. So staging, right? So we talked about staging and grading. When we talked about staging, we talked about that T and M system. So that's how we figure out how big the tumor is, if it's gone to lymph nodes, if it's metastasized, if it has, then we'll give it a stage 1, 2, 3, or 4. And that grading is more so involved with actually looking at the cells with a microscope. We don't normally get involved with that in primary care because that's going to determine how the oncologist is going to actually treat the cancer. Okay? So which of the following are known causes of cancer? All of the above, right? It's pretty simple. Any number of these can cause cancer. There's also many, many more. But as long as you are familiar with the ones that I put in your lecture, just be familiar with those, okay? So this one's a little bit different. I didn't really talk about the Guyatt test, but go ahead and read it and then let's kind of see how you respond. We got things. Based off what you have, right? So this female has constipation. Okay, we're thinking GI tract. She's got blood in her stool. You remember some of the markers from last lecture? Probably not PSA, but that's the prostate. Probably not none of the above because they don't do that on pins. What y'all thinking? What was that? What was that? B. So the correct answer is B, right? CEA. So that's one of the tumor markers that you can sometimes use if you are looking for colon cancer. This is kind of trying to paint that picture in a very simplistic way. That Guyatt test, that's a test that you'll be able to do that you'll order on your patients if you think there's maybe blood in the stool. But sometimes when a patient has blood in their stool, it's not going to be bright red, right? Or maybe it's such a small amount that the patient doesn't notice it. So if you're working up some type of GI tract issue, and you think there's bleeding going on, then you can order a Guyatt test, and then if it's positive, then that means that maybe there's some type of blood going on. So another way to kind of look at this question. So you got a positive Guyatt test, you got a positive CEA. What do you know about cancer? How about weight loss, right? So if a patient presents with unexplained weight loss, that should hopefully key you in that maybe there's some type of cancerous process. Doesn't always mean that's the case, but if you ever have that, maybe consider it because you never know. Cool. Alright, so today, again, I think it's also interesting, this topic. We're going to be talking about genetics, but more so genetics in a way of how patients may develop certain genetic abnormalities, different traits, right? Because definitely on the parents, they're going to get to some very common things that you might see in clinic. Typically in the military, you're not going to see a lot of genetic problems, especially when it comes to like when a child's developing, right? But potentially you could catch some things, and I'll kind of point out a few of these circumstances where there's an increased incidence of certain genetic disorders that you might see in your clinics because they didn't get caught during the whole meds when they were processing through meds. So to focus your attention, if you look at that middle kind of center there, where it says genotype and phenotype. So genotype, all that means is that those are the genes that you inherited from your mom and your dad, right? We get our genes from our parents. Our mom gives us a certain amount of genes, half of her genes, right? Our dad does the other half. And that genotype is what we have. Now, we may not express that genotype because we may have a gene from our mom or our dad that's more dominant, and so we're not going to express it. But if we were to somehow look at our genes and kind of see what's written there, that would be our genotype. So sometimes they're expressed, sometimes they're not. When they're expressed, we call that the phenotype. That's what we physically see, right? Now the phenotype definitely, it's based off our genotype, but it also has to do with our environment. And I'll explain what that means here in a few slides. But in order for us to physically see something, our phenotype, we need our genes, and then our environment plays a big role in that as well. Hereditary disorders, so that's pretty simple. These are those disorders that we actually get from our parents, so they're passed down from our parents to us. And then familial disorders, these are kind of a mix, right? These are things that run in families. There may be a genetic component to it, but oftentimes the environment plays a big role. So if you got a family and everybody in the family has high cholesterol, well, maybe there's a genetic component to that. Maybe they have genes because somewhere down the line, somebody had high cholesterol and they made this gene, so it got passed down. But also too, what about the family? Like, is the family eating healthy? Are they eating cheeseburgers every single day, or are they eating chicken and salad, right? So the familial disorders, there may be a component to the genes they inherit, but also too, you got to look at their environment, what they're doing on a daily basis. Because it doesn't necessarily always mean that just because there's a family history of high cholesterol, that's because it's a genetic problem, if that makes sense. So it's kind of a broader term, and oftentimes your patients are going to have a mix of this. They're going to have some type of genetic issue, but also look at their lifestyle. What are they doing that may be contributing to whatever disorder that they have? And then congenital disorders. So congenital disorders, obviously when a child is born, if they have some type of disorder, something going on with their body, it doesn't always mean that there's a genetic cause. And there's an example over here that shows a diabetic mother who has a large baby. So there's no gene causing this baby to be large, right? What's happening here is that the mom has high blood sugar. That sugar is small enough to cross the placenta. The baby's pancreas is making insulin, but insulin is also a growth factor. And so it's causing that baby to grow large. It doesn't mean that the baby, there's something wrong with their genes. It's just that mom has high blood sugar, it's crossing the placenta, and now that baby's pancreas is doing what it needs to do. Make sense? All right. Some other key terms here. So with genes, sometimes with our cells, when they're replicating, sometimes there can be problems with the replication. So they can get these structural abnormalities. And we're not going to spend too much time on that, but just understand that when cells replicate, there can be a problem with the way they replicate. And so you can have deletion where you lose a portion of that DNA sequence, or sometimes you can have inversion where when it's trying to replicate, it actually flips on itself, and that can sometimes cause problems with the things we're supposed to make. What we're really going to focus on are the numerical abnormalities and the single gene disorders. So with numerical abnormalities, think of these as we get our chromosomes, we get our genes from our parents, and for some reason we either get an extra chromosome or we lose a chromosome. And I'll show you an example here in the next few slides. For the single gene disorders, there's a mutation in the single gene that we inherit. Now some of these, so for example, autosomal dominant, if we inherit a mutated copy of a gene, and that gene is dominant, if we get one copy that's dominant from our parent and then another copy that's recessive, that dominant gene is going to take over that recessive gene. So we're going to actually display that trait, that disorder, if we get that type of gene inherited from our parents. Versus recessive, we need two copies of that abnormal gene in order for us to actually express that disorder. And then there are some that are on our sex chromosome, especially our X chromosome that we get from our mom. If we get a abnormal chromosome from our mother, especially if we're a male, then we're going to display that abnormality because we only get, if you're a male, you only get that X chromosome from your mom. Your dad can't give you that because all he has is that Y chromosome to give you. So if there's a recessive disorder or a recessive trait, some type of abnormality on that gene, and you're a boy, and you just have that X chromosome from your mom, and you're going to display that disorder. And then that last one down there, multifactorial inheritance. So this is probably truly how a lot of things you're going to see in clinic are going to manifest. Because it's not as simple as, oh, I got one abnormal gene from my mom or one abnormal gene from my dad, so I got this. No, it's a mixture of multiple genes that come together that really impact our patients. So hypertension, diabetes, things like that. There's not a gene, just one gene for hypertension. There's multiple traits that come along, and then also to lifestyle. Take height, for example, right? So we are going to, when a child's developing, they're going to reach a certain height eventually, right? But they're going to get that height gene from both their mom and their dad. But also too, their environment, their nutrition. If they're not getting that proper nutrition, they're not going to reach that maximum height that they could. So environment does play a big role in that as well. But we're not going to focus on that too much. The main things we're going to look at are those numerical abnormalities and those single gene disorders. So developmental abnormalities. So when we talk about when a fetus is developing in the womb, right, there's something called morphogenesis where all that means is that they're developing their organs or body parts. Now the problem with this is that especially in that first trimester, that's when that morphogenesis is occurring. And so if you introduce something during that first trimester that could potentially impact that child, then they're going to potentially have this abnormal either organ development or type of abnormality that comes to play. And if that occurs, the mother has the mother's body kind of can sense that. They can see that the baby's not developing correctly, and potentially that could result to a miscarriage. There's different kinds of abnormalities that can happen. We got agenesis, where you don't develop an organ or structure of the body. You got aplasia, where you're developing the organ, where you're developing the tissues for that organ, but it's very rudimentary. It's not going to function normally. And I have there on the blue there, in that blue box, that they're usually non-viable births. Now, it just depends on the organ. So I'll show you a picture here in this next slide. If you have agenesis of a kidney, one kidney, well, as long as your other kidney develops normally, baby's going to be fine. That child's going to have to probably take precautions as they get older. They're going to have to, probably not play contact sports to protect that kidney, but overall they're going to live. They're going to be normal and healthy. With atresia, so what that means is that you don't have an opening in the tubular space. So there's something called esophageal atresia, where sometimes that esophagus doesn't connect down to the stomach. Now, hopefully you catch that during your fetal screens whenever a woman is pregnant and they're doing the ultrasound. But sometimes it's hard to appreciate that, especially on an ultrasound. So how these kids will present is that they go to have their first feed, and as soon as they start feeding, it's going to come back up because there's no opening to that stomach. You can also have rectal outlet atresia, so you don't have an opening to your rectum. And so that's why we check kids to make sure they pass that first stool within 24 hours of life, just to make sure that there's an actual connection. Hypoplasia, that means that you develop the tissue, you have the organ, but it's smaller than normal. It could be either from small cells or not enough cells, but overall that organ is still there. And again, if you have a paired organ, if you have two kidneys, for example, and you have one that's hypoplastic and one that's normal, again, that child's going to live a normal life. That organ is still functioning, it's still doing what it needs to do, probably not as efficiently as the other organ, but if you have hypoplasia, as long as you have a paired organ with that, you're probably going to be fine. And then involution failure, so remember I talked about syndactyly, how we can have the webbing kind of persist throughout life. So that's all that means, is that for some reason what was supposed to die off didn't. And we know about 25% of the reasons behind these malformations, right? But there's still quite a bit that we don't know. So that term idiopathic, all that means is that this is a fancy medical term explaining that we use to say we don't know what's causing this. So this slide here is not in your slides. I threw it in there last night just more for visual. Hopefully it kind of helps kind of paint the picture that I showed you, or I was trying to explain in the last slide. But if you look at this baby's kidneys, right, up top, normal, down below, we got agenesis. They still have that one kidney, but the other one they're missing. They're going to be fine. That aplasia, they made some type of tissue cell, but it's not going to do anything. But as long as they have that other kidney, they're going to be fine. And the hypoplasia, I've definitely seen this before, like the hypoplasia, where somebody has a normal kidney and the other kidney's kind of small and shriveled. It's still doing something, but it's not going to work as efficiently as that other kidney. All right, so teratogens. So there are certain things that we know will cause fetal malformations. They're termed teratogens. Don't confuse this with carcinogens, right? We're not talking about cancer here. We're talking about fetal development. So don't let those two terms confuse you. So we know that CTs, X-rays, radiation, we avoid those in pregnant women because if we introduce any type of ionizing radiation to a woman who's pregnant, especially during that first trimester, we have the potential to cause these abnormalities in the babies. Chemicals, alcohol, that's probably the biggest one, and it's preventable, right? Women don't have to drink alcohol when they're pregnant. Some do, and that can sometimes be an issue, especially when you're seeing them in clinic, because you want to, they hopefully know that alcohol is not good for them, but some women still choose to drink here and there, a drink or two. But the problem with alcohol is that there's no recommended guideline intake for a woman to drink alcohol. There's no safe amount, right? And so if a woman is drinking alcohol, especially if she's consistently drinking alcohol during pregnancy, then definitely she has that risk of having a child who has fetal alcohol spectrum disorder. And we'll talk about this in a few, I think next block we'll get into this. But with these children, they're going to have this kind of intellectual development delay. They're going to have certain facial features that are characteristic, like low set ears. And they're going to have problems with the development of their organs inside their body, like their heart. So if we can educate our women and say, hey, especially when they come in and they're thinking about becoming pregnant, because they're going to come into you and they're going to ask you, hey, I want to start having a family. I'm at a point in my life where I think I want to have a child. They're going to come to you for advice. And this happens quite a bit. And so you want to make sure you are educating them on things to look out for and things to avoid as they're preparing to have that child. Torch. I'm not sure if Micro got into this with you last semester, but there are certain pathogens that we know cause fetal malformations. How many of you have cats? Anybody have a cat? Yeah, cats, right? I have a cat too. He's okay. I don't know. He's kind of in the butt. But cats can sometimes develop this parasite, right? Toxoplasma gondii. And if they have that parasite, they release it in their stool. And if you have a pregnant woman who goes and cleans the cat litter, and she inhales these fecal material that have that parasite, and that can cause problems with child development if she's pregnant. Rubella, so we vaccinate against this, MMR vaccine, right? So we try to vaccinate against this, but in our women who maybe are hesitant to receive vaccines, or maybe that vaccine has lapsed, then if she's not fully protected, then she has a chance of catching this during pregnancy. And with rubella, that can cause a lot of issues like cataracts. It causes deafness in the children. So again, when these women are coming to see you and they're asking for, just letting you know they want to become pregnant and coming to you for advice, make sure they're up to date on their vaccines, make sure that they know to avoid cats, right? Make sure that they're best prepared in order to hopefully reduce that chance of having some type of fetal abnormality whenever they are pregnant. So numerical abnormalities. So just some more key terms here. When we talk about numerical abnormalities, so as you probably already know, we have 46 chromosomes, right? And they come in 23 pairs, and we get those chromosomes from one half from mom, one half from dad. When we write this out, if we're writing it out, the way we annotate this, a normal amount of chromosomes is we say 46, and then whatever chromosomes they receive from both their parents. So if they're female, they receive one X from their mom, one X from their dad. So we say 46 XX, and that annotates that this female has the correct number of chromosomes, and she's a female. But that XX, those genes those sex chromosomes you get from your mom or your dad, they're included in that 46. So it's not, doesn't mean that she has 46 plus the XX. They're both included in that total of 46. Same thing with the male. If it's a male, they're going to get one X from the mom, one from the dad, but those XY chromosomes are included in that total 46. Make sense? Now, if there's a extra chromosome not on the sex chromosomes, then what we do is we annotate that by saying plus wherever that abnormality is. So for Down syndrome, that abnormality, that extra chromosome is on chromosome 21. So in this case here, we got a female who has an extra chromosome at 21. So she's 47 XX, and then we write plus 21. If the abnormality, if the extra chromosome is on the actual sex chromosomes, then we don't have to write plus whatever, because what we're going to do is we're going to just annotate that and we write out that sex chromosome. So for Klinefelters, this person has 47 chromosomes, but they have two X's instead of one. So they're XXY. If they're missing a chromosome on that sex chromosome, then we use 0 as a placeholder. So for Turners, they're 45, they only have 45 chromosomes, but they just have the X. They don't have another X, or they don't have another Y. Cool? All right, so this is a karyotype of somebody with Down syndrome. And you can see that on chromosome 21, instead of having those two there, they have an extra one. And this person would be a male because if you look at their XY, if you look at their sex chromosome, you have XY. So with Down syndrome, this occurs in about 1 to 800 live births. And the biggest risk for this is maternal age. So if a mom is getting older, she has an increased risk of having a child with Down syndrome. So you see there, if she's 45 years old, she has a 1 in 25 chance of having a child with Down syndrome. It doesn't mean, so if a woman comes to see you, and she's a little bit older, and I'm not saying that's old, but she's a little bit older, it doesn't mean she can't have a child. It doesn't mean that she's going to have a child with Down syndrome. It just means that you need to make sure that that mom is aware of her risk, right? Because if she knows this, say she is 45, does she want to take that risk on? Because potentially if you have a child with Down syndrome, there's going to be a lot of care, long-term care involved with that, right? So you just want to make sure that your women are knowledgeable about those risks, especially as they get older. So typically when they're 35 and above, they're considered advanced maternal age. Don't tell my wife that because she wants to have another kid, but I'll try. But and so you got to be careful, right? You just got to make sure that they're aware, because if they know that risk, then maybe that might change their outlook. So the way this happens, right? We don't really understand fully why this happens, but we do know that there's a problem with oocyte whenever it's proliferating, whenever it's trying to replicate, right? So with the oocyte, so it goes through meiosis, right? There's meiosis 1, meiosis 2, if you remember that from whenever we took that back before you got here. But there's a problem. That chromosome 21, it doesn't separate completely. So 1A gives 2 chromosomes of chromosome 21, and another egg doesn't, and then the other daughter cells receive their normal 1 chromosome. Then comes the sperm cell. It does this thing with that egg, right? It forms, but now you're getting another chromosome from your dad, so that's another 21 chromosome. But it fertilizes that one egg that has the 2, now you have 3 copies of chromosome 21, and that's how these, that's how Down syndrome is actually formed. This is how this happens. Now with Down syndrome, the most common thing you're going to see with this is that they're going to have some type of intellectual disability. Now it varies. If you ever had a family member with Down syndrome or met somebody with Down syndrome, it could be pretty severe or it could be mild, but there's some level of some type of intellectual disability. They're going to have characteristic facial features, so they're going to have a flattened face, their nasal bridge is going to be a lot lower, their eyes are going to be close together, they're going to have slanted eyes, and they're going to have something called epicanthial folds. So all that is that the top of your eyelid, right, normally when you don't have Down syndrome, it kind of comes down to that medial aspect, and it comes to a point. With the epicanthial folds, that upper eyelid, when it comes down medially to the inner part of your eye, it's going to be blunted. So you can see that in children who have Down syndrome. They may have a large tongue, which will get in the way of their talking. So if you ever heard somebody with Down syndrome talk, they kind of have this it's kind of like something's in their mouth when they're talking, right? It's not as clear. They may have some internal organ defects. So probably the biggest thing with these guys is that they'll have heart defects. The biggest thing with them is that they have holes in their heart, especially in that atrium. So they have these ASDs, atrial septal defects. And they're at more risk for having leukemia as well. And that's what, hope, if they get proper medical care, if they get regular routine care, most of the time these kids, they live a long and healthy life. But if there is some type of, they don't get that proper care, and that's what typically causes death in just individuals, either from leukemias, from some type of heart defect that wasn't caught in time and caused problems later on down the line. All right, so just a picture of Down syndrome, right? So you see there that if you look at that side profile, that face is a little bit flatter. The epicanthial folds, so you can see how instead of coming to that sharp angle, it's blunted. And then the simian crease. So if you look at your hand, normally if you look at our hand, we have these creases. We have multiple creases, but with these children, they're going to have what's called a simian crease. So it's going to be a single kind of transverse crease on the palm of their hand. And the reason why they call it simian crease is because if you look at the great apes, right, the gorillas, they typically have that same fold, that same not defect, but that same fold. So that's where that name came from, the simian crease. All right, so Klinefelters and Turners. So these are problems on the sex chromosomes. So with Klinefelters, you can see there that there's two X chromosomes plus that Y, and then with Turners, they're missing a chromosome. There's no other X or Y there. So with Klinefelters, again, it's going to be a XXY. Because they have that Y chromosome, they're going to be males. They're going to look like men. They're going to develop male characteristics. And look at that, the incidence: 1 in 700 men, right? 1 in 700 births. So chances are, you're going to see 700 patients probably within 2 months of being a PA, right? So you're going to one day run into this. It's out there. The thing with these guys is that when they're growing initially, when they're children, you're not really going to notice it unless you have some type of family history that makes you suspect it, right? But when they hit puberty, that's when you're going to really start to notice that this person is not developing normally. Because with Klinefelters, you're not going to have normal testicular growth. They're going to be underdeveloped, and so your testicles are what make your testosterone or make your sperm. So a lot of these guys are going to not develop those secondary male characteristics. They're going to be infertile because they're making little to no sperm, but without that testosterone, they're going to keep their kind of youthful appearance. They're going to look boyish. They're not going to have a lot of facial hair, a lot of body hair, because testosterone is what makes men develop the hair where they grow hair in certain places, right? Their chest, their face. Their genitalia, they're not going to be as developed, right? And then they also may develop something called gynecomastia. And what that means is that just a man who has breast tissue. And so testosterone, what that does for men is that it counteracts the effects of estrogen that we make. We make estrogen as well. But when we don't have testosterone there to counteract the estrogen, well then now we're going to start making breast tissue. And you'll see a real life picture here in a second. They are going to be tall and they're going to have these long arms and long legs, and that's because testosterone helps close those growth plates. And so without enough testosterone, we're going to leave those growth plates open a little bit longer, and so these individuals they're going to have these kind of long arms, and they're going to be a little bit taller. And then potentially they're going to have learning disabilities. That's not always the case. Sometimes, most of the time they actually don't, but there's always a risk that they could potentially have some problems with the cognitive function. Now with Turner syndrome, this is different, right? We're missing one of the sex chromosomes. And because we just had that X chromosome, they're going to be females. Now this is more rare, 1 in 3,000 females. But the problem here is that without that extra X chromosome, she's not going to develop her ovaries correctly. So she's going to develop something called streak ovaries, which are essentially ovaries full of fibrous tissue. And without actual ovarian tissue, she's not going to make estrogen like she's supposed to. She's not going to have a menstrual cycle. She's also not going to develop breasts, and her nipples are going to be widely spaced apart. She's going to be short, and it's not so much because of estrogen. On the both X and Y chromosome, there are certain genes that play a big role in how tall we are. So without that other X or Y gene, she only has one of it, so she's not going to grow tall like she should. This webbed or brown neck, so it's kind of flaring of the neck. So what happens here is that with this, the X chromosome and the Y chromosome, but if you just have one, that plays a big role in how your lymph vessels develop. And so when these children are born, sometimes if they don't have a proper amount of lymph vessels that develop or mature enough, she can develop this fluid in her skin. And it can happen in the neck, and it can happen in her hands as well. And so when that happens, it can actually stretch out the skin. So if you've ever seen somebody who's been very overweight and they lose a ton of weight, they've got this excess skin, this is essentially what's happening here. Now as she gets older, those lymph vessels are going to start making these collateral vessels, and they're going to dilate, so that swelling that you get initially is going to go away, but it's going to leave this kind of webbed neck or pulled out skin appearance. She's going to have pubis valgus. So what that means is that, so normally when you stand in the anatomical position, your arms go straight out, right? For her arms are going to bow outwards, so they're going to bow out to the side, especially at her elbows. And then some other internal defects. So these ladies also have heart issues at times. So that's why whenever we catch this, we got to make sure that we are getting them to the right location. That way we can hopefully prevent these complications that develop later on. So Klinefelter, so these are real life pictures of individuals who have these syndromes, Klinefelters and Turners. So you can see over there the Klinefelter. If you look at the picture on the right, on the right there, you can see if you look at that boy's chest, it kind of has these small little breast tissues, right? That's that gynecomastia. So it's not going to be like large breasts, but it's going to be some type of breast tissue that develops there. With Klinefelter, you can see there that webbing of the neck. You can see how her arms kind of bow out like that, and she's very short. So autosomal dominant disorders. So with autosomal dominant, right, these genes that we get, if they have a mutated copy and it's the autosomal dominant disorder, all you need is one copy of that gene for that person to express that disorder. Okay? Now they can inherit it in a couple of different ways. They can be homozygous, meaning they get one defective copy from their mom and one defective copy from their dad. So they have two abnormal copies, so they're homozygous. Or they can develop it, they can inherit it in a heterozygous pattern where they get one abnormal copy from their mom or dad, and the other one is normal, right? But if you just have one copy, if you have one abnormal copy, that gene is strong enough to overpower the normal copy, which causes that disorder in this individual. Make sense? So you see down there, there's a Punnett squares, and if you know the actual genotype of a person's parents, you can sort of determine the risk of that child having that disorder. So Marfan syndrome, this one's rare. It's a connective tissue disorder of something called fibrillin. And think of fibrillin as like the glue, like it says on there, that kind of holds our connective tissue together. It gives it strength, but it also gives it the elasticity that it needs, right? But fibrillin does something else. In a kind of roundabout way, it helps control the chondrocytes, and your chondrocytes it's what's in your growth plates. And if you don't have enough fibrillin or you have defective fibrillin, those chondrocytes are going to proliferate quickly. And when that happens, when you get proliferation of those chondrocytes in those growth plates, it's going to cause them to proliferate and grow more and more. Then eventually that bone's going to lay down. But if you have more chondrocytes when those growth plates are still open, that individual is going to be a lot taller because they have more of that kind of foundation there for that bone to actually form over. But without the fibrillin, these individuals are going to be tall. And they're going to develop these long fingers and long arms because, again, they didn't have that control over the chondrocytes, so we're going to have these long bones, especially in their hands and fingers. And then they're going to have weak ligaments and joints, so a lot of these individuals are going to have kind of be at risk for developing some type of dislocation, especially the shoulders or the elbow, wherever the joint is, right? Because you don't have that strength there anymore to help give it support and prevent the actual dislocation. Aortic aneurysm, so you have connective tissue everywhere, right? Especially in your arteries. If you don't have that fibrillin there to give the arteries the support and the strength it needs and that the elasticity, then what happens is, think about your heart. It's pumping all this blood at every single minute, every single second. Over time, it's going to dilate that aorta and cause an aneurysm, cause it to grow out and pouch out. It can weaken the aorta and cause what's called a dissection, where the internal lining of the aorta starts to tear, and so now blood's flowing into that internal lining, and then potentially it can rupture. And if you have an abdominal, or if you have an aorta that ruptures, not good, because unless you get to an ER really quickly, unless you're in the ER when it's happening, it's going to be very, very hard to stop that and prevent you from bleeding out. Also the eyes too, so your lens of your eyes is controlled, it's held in place by connective tissue. Well, if that thing is weak, if it's not strong enough to keep it in place, then you can have dislocation of that lens. We got a picture of Abraham Lincoln there because it's suspected that he had Marfan syndrome. Now there was no genetic testing back then to really determine that. But he's one of those guys who we think maybe had Marfan's. So just some pictures for you guys. So you see that lens, how it got dislocated? It's not in the right place. So the person's going to have some severe visual difficulties. He's going to have those long arms and long fingers, long limbs. And then that picture there of the heart, you can see that aortic aneurysm. And then the picture next to it, there's a tear in there, so that blood is starting to flow into that inner lining of the aorta. And if we don't catch it in time, it can actually rupture and cause death. So next one, familial hypercholesterolemia. So look at this one. 1 in 500 Americans have it. So you definitely will see this in your clinics, right? Now the severity, there's a wide range of severity on this, and that's because there's different types of abnormalities that can develop here, right? I'll explain what I mean by that here in a second. But essentially here, so your liver normally has these LDL receptors, right? And those LDL receptors help take that bad cholesterol, that bad LDL, out of circulation. In the most common deficiency, you don't have enough of those receptors. There's like 4 or 5 of them, but this is the most common one. So if you don't have enough of those receptors on your liver, then you're going to have an increased amount of LDL. And you know HDL, LDL, HDL is your good cholesterol, LDL is your bad cholesterol. When you have a high amount of LDL, that LDL, what it's supposed to do is take your cholesterol from your liver to your body to actually do what it needs to do there, right? When you have a high amount of LDL, it's going to start to precipitate, it's going to start to get into places where it shouldn't, where we don't want it to, like the heart, like the aorta, or not the aorta, but the vessels in your heart, your skin sometimes. And so The HDL is still working. The HDL is still taking the cholesterol and taking it to the liver to be processed out. But without those LDL receptors there, you're going to have an increased amount of LDL, which is going to increase that risk of having atherosclerosis, having a heart attack. And if you have a high amount of cholesterol floating in your blood, it's going to precipitate into our skin. So you can get these kind of cholesterol plaques called xanthomas, and they can occur around the eye, they can occur around our tendons in our hands and our Achilles. So if you have somebody who has very high cholesterol, make sure you're looking at their face, but also check their extremities, check their skin, check their hands. Have them take off their boots and look at their Achilles tendon, because these are common places where those xanthomas actually can be seen. Now, there's no cure for this, right? There's no cure to try to get those LDL receptors back on the liver. So the way we normally treat this is by dietary modification. So explaining to our patient, hey, you need to cut down on things that have high LDL, high cholesterol, and then statins. And I don't know if you've hit statins yet in pharmacology, but statins are the number one way we treat high cholesterol. But it can sometimes, but even then, sometimes you can hit a patient with a high dose, the highest dose of a statin, and that's still not enough to get them to the goal that you want to get them to, so you might have to add on more medications. But statins are the kind of initial first go-to medication that we'll do to treat high cholesterol in these patients. All right, so autosomal recessive. So with this one, you have to inherit 2 abnormal copies from your mom and your dad in order for you to express this disorder, right? So if you have 1 normal copy and 1 abnormal copy, you're not going to express this disorder. You're going to be a carrier for it. That means it's in your genotype, but you need 2 of the abnormal copies to actually demonstrate that you have this disorder. So again, kind of going down below, if we look at that first box, dad's normal, he's got 2 normal copies. Mom has both abnormal copies, right? So she's homozygous because she has both abnormal copies. But when they have children, all their children are going to be carriers, but none of their children are going to actually express this disorder. They're not going to demonstrate it because they have that normal copy that overrides that recessive copy, that normal copy. If you have one parent that's homozygous, so mom's homozygous, so she has 2 abnormal copies, and dad has 1 normal copy and 1 abnormal copy, then 2 of their children are going to express that disorder because they have two of those abnormal copies, but 2 of them are going to just be carriers. They're not going to express it. Now, if they have children, and if they have children with somebody who has, either the recessive is homozygous for the recessive copies or heterozygous, then they potentially can have children that have that disorder. But in this case, they're just going to be carriers for 2 of them, and then 2 of them are going to actually have the disorder. So cystic fibrosis. So this is probably the most common, most lethal autosomal recessive disorder that's out there, and it mostly affects Caucasians, especially from that northern European area like Finland and Norway and things like that. And what happens here is that you have a defect in a protein called the CFTR protein, and that protein, the main job of that protein is to help chloride go from inside the cell to outside the cell, and typically outside the cell to the lumen of the space. So it could be the lungs, it could be the pancreas. Now, if you don't have that protein, that chloride is not going to escape the cell and go into the lumen of that space, right? So let's think about the airway right now. Well, what that protein also does is it helps control how much sodium you reabsorb. And so if you don't have this protein, you're not pushing out chloride like you should, you're not controlling the sodium reabsorption, you're going to have more sodium reabsorption. Well, if you're trying to push out chloride and sodium to a space, what's going to try to follow that? Water, right? And our lumen, our airway, normally makes mucus. We normally make mucus, that's a protective, normal part of our airway. But if we're not pushing out chloride and we're taking more sodium back into the cell, well then that mucus that is in your airway is not being hydrated. So as a result, it's going to be sticky. It's going to be thick and sticky. And so trying to get something thick and sticky out of your airway is a lot more difficult than if it was hydrated, right? So what these secretions do is they get thick and sticky, and they can block the airway, or they can block lumens like in our pancreas, which help which are important for the digestion of certain things that we eat, right? But especially in the airway, if you have these secretions in your lungs that you can't get out, and you have bacteria that gets introduced, well, now you got the perfect medium for bacteria. It's dark in there, it's moist in there, and now you got these secretions that are thick and sticky. So now these kids are going to have lots of pulmonary infections. They're going to have pneumonias, right? They're going to have these recurrent pneumonias. Now, one pneumonia, a couple of pneumonias here and there, not a big deal. But if they're getting, this repetition of pneumonia, then that's going to cause inflammation. That inflammation is going to cause damage to our lungs, right? And so if these kids are getting these chronic infections, they're developing this chronic damage in their lungs, they're going to develop severe lung complications. And that's what typically causes death in these individuals. When we think about the pancreas, I already told you that the pancreas has to release digestive enzymes. So if we block the lumen to where those enzymes can actually escape the pancreas and go to our small bowel, well, now we're not releasing those enzymes that help us break down fats, right? And so we're not getting that nutrients that we need, and so these kids are going to be a lot smaller too. They're going to be malnourished. Now there's a way to test for this. There's a couple different ways. One is called the pilocarpine or the sweat chloride test. So I told you that in our airway, right, that the chloride, that protein helps chloride escape the cell, right? If we don't have it, then it's not going to escape. In our sweat ducts, it's different. It acts differently. In our sweat ducts, that protein helps us reabsorb chloride. So we sweat, we release chloride through our sweat glands, and then that protein's job is to help us reabsorb chloride in the sweat gland. So when they don't have this protein, and we do this sweat test, we apply the solution of pilocarpine, we apply this electric current, and then it causes a localized area of sweating. And then when we take that sample and we send it to the lab, if they don't have this protein, they're going to have an increased amount of chloride in their sweat. Because normally that chloride should be reabsorbed by that protein in the sweat gland. It's different than the lung, right? So that's how we determine whether or not somebody has this disease, by doing that. And then if we have doubt, or if we want to confirm the diagnosis, we can always send them for genetic testing. But that pilocarpine sweat test, that's the gold standard, if you will, of trying to diagnose this in somebody that you suspect has this disorder. All right, phenylketonuria, so PKU. This thing is rare. This is a rare thing, but it's out there, and you're probably going to see it's probably on your pants, because I've seen this quite a bit on the first pants when I took the pants initially, and then when I recertified, I saw another question about this. But in this case, with these individuals, they don't have a certain enzyme called phenylalanine hydroxylase. So this enzyme, its job is to take phenylalanine, which is an amino acid that we consume, right, and turn it into tyrosine. Now, tyrosine and phenylalanine, they're important for brain development, right? Well, if we have too much phenylalanine in our blood, it can actually cause issues within our brain. It can cause you're not going to make enough neurotransmitters in some cases, and it can cause seizures and some type of developmental delays as well. But if we don't have this enzyme, and we have too much phenylalanine, then what our body tries to do is say, okay, we got all this phenylalanine, we need to get rid of it. It uses alternative pathways to try to get rid of it. But when it does that, we're going to start urinating it out. So we get these things called phenylketones in our urine. Okay? Now, with this disorder, oftentimes in the beginning, the baby's going to be fine, right? They're not going to have an increased amount of phenylalanine because they haven't been, it takes time for that stuff to build up into our body to where it becomes toxic. But if we don't catch it, and we're, breastfeeding the baby, then we are increasing the amount of phenylalanine because they can't break it down fast enough. They can't get rid of it. And when it accumulates in the brain, it starts to cause seizures and, like I said, mental disability. Phenylalanine also does something weird. It suppresses your melanin production. So a lot of these individuals are going to be fair skinned, and they're going to have kind of a lighter hair color. And I don't know, don't ask me what this smells like, but they're going to have this musty, mouse-like odor. I left it in there because every board I've taken, when they talked about this condition, when they describe a patient, they always describe this mouse-like odor. It's from the metabolites. I don't know what it smells like. I imagine probably like a wet dog. But that's something that I've seen on the pants and my pantry when I took it recently. So Just know that as a key word, and if you see that, think PKU. So the way we test for this, so if you've ever had children, the lab's going to come and take your child, right? Typically what they're going to do is they're going to do a heel stick. They're going to take this little lancet and prick the baby's heel. And they're going to take that blood that they get from the heel stick and they're going to spear it on the specialized card. And they're going to send that card off to another lab to be evaluated. And a lot of states require this, right? Because this thing is so potentially deadly that if we don't know about it, then we can cause a lot of undue harm to an individual. But with phenylalanine, I already told you it's an amino acid, right? Amino acids come from proteins, and so these individuals have to have a pretty strict diet. They can't eat protein pretty much at all. They have to avoid all the good foods, meat, chicken, fish, anything that has protein, they have to avoid it. And they also can't have Diet Coke, right? So Diet Coke has aspartame that also has phenylalanine in it, and so if these individuals drink Diet Coke, they're gonna have some pretty severe outcomes. And that's why if you look at a Coke label, a Diet Coke label, you'll see there on that red there, it says, hey, don't drink this if you have PKU, because you can potentially have some bad outcomes. All right, let's take a 10-minute break.
Okay, so a 13-mile run before right now, let's go.
Be driving nowhere with this.
I was thinking about that.
He's one of them.
Alright guys, we're almost done. Get your eyes, beat that traffic. Alright, so X-linked recessive disorders, right? So these are the things these are those genes that you're going to get from your mom. And so like I told you, in order for somebody to have this disorder, they have to get one abnormal gene from their mother. Now, for the recessive disorders, for the X-linked recessive disorders, it doesn't follow the normal inheritance pattern. So I already told you previously that in order for somebody to have the disorder, if it's recessive, you have to have both of them, right? Now for X-linked recessive disorders, it's going to primarily affect the men more than the females because the men only get one X chromosome from their mom and the Y from their dad. So the men do not have that other X chromosome to help protect against whatever recessive trait that they inherit from their mother. So if you have a son and he gets that defective gene from the mom, well then he's going to display that disorder because there's no other X chromosome there to protect it. Make sense? The Y chromosome doesn't have the same types of chromosomes that the X does, so he doesn't have that protective factor. This thing in the box here with the pirate thing, I left it in there, just maybe it might help some individuals kind of picture this more so. If you think about the Y chromosome that's missing in the allele, then maybe that will help you understand this a little bit more. It seems like you guys understand that already, so maybe I'll take it out next semester. But I left it in place because it was something from Mr. Weber that he felt like helped students kind of put this together. So, but I think that it's pretty, I don't know, it's pretty evident to me. Women can have this as well, but it's very, very rare. It doesn't happen often. So most of the time when you have these disorders, it's going to be in your So there's several here. So we got hemophilia, Duchenne's muscular dystrophy, and Fragile X syndrome. So with hemophilia, there's a problem with the coagulation factors, right? Now hemophilia A, there's either a deficiency or a lack of factor VIII. Now most of the time it's a deficiency, so you still make some factor VIII, but you don't make a lot of it. And so potentially you could have easy bruising or easy bleeding, but most of the time when you have this, as long as you're making enough factor VIII, the patient may not even know they have this. It just depends on the amount of factor VIII that's deficient or missing, and the more that they're missing, then the more severe it's going to be. But typically this is going to be a little bit of a deficiency, but they're still going to make some. But that's the most common hemophilia A. Hemophilia A is the most common one from this. Hemophilia B is typically more severe, and that affects factor IX. And it's more severe because typically these individuals are going to be deficient in it. So if they don't have really any of those clotting factors, then they're going to have problems with trying to stop bleeding. With factor IX, most of the time they're not going to have any at all, and so they're going to bleed, especially with minor trauma. They could bleed into their joints. They could, if they're having menstrual cycles, they could bleed excessively. So now we can treat this. We have medications to treat this, but if you don't know about it, right, especially in hemophilia A, you may not need to treat that in honesty. But if it's especially hemophilia B, then we have things that we can give the patient to help them make those clotting factors. With Duchenne's muscular dystrophy, with this one, there's a problem in something called dystrophin. So it's a protein that helps the muscle kind of sustain it against stressors. And if we don't have this protein in our muscle, then those muscles start to break down with minor stress. When they start to break down, they start to disintegrate, they start to die, and so our patients are going to be very weak. They're going to be very weak, and it's going to be a slow process. It doesn't happen like that. Now, unfortunately, there's no cure for this. We can get them to physical therapy. We can try to help reduce the muscle breakdown that occurs, but over time, these muscles are going to break down so much that eventually they're going to pass from this. Typically, they're going to pass from some type of heart-related issue. With Fragile X syndrome, so with these guys, they're missing something called Fragile X mental retardation protein. So with this protein is important in brain development. And if you were to, or brain development, and as a result, they're going to have this kind of intellectual disability. Right? They're going to have problems with learning. They're going to have kind of a pretty severe mental retardation. If you were to look at their chromosome, so if you were to look at their X chromosome, it would look like it's fragile. It has, if you look at the bottom of it, it looks like there's a small piece and there's a wide gap. It looks like it's broken. So that's where this name came from. It's because that X chromosome in real life, if you were to look at a karyotype, it's going to have this kind of weird abnormality at the very bottom of it. And they also have these characteristic facial features. So they're going to have this broad forehead, long face, these big ears. And so, again, with this one, there's nothing you can really do for it besides just try to, make sure they're getting the regular medical care that they'll need. So prenatal testing. So, like I told you, there's a lot of things that we can't do, right? We can't control certain inheritances that we receive. Oh, go ahead.
How would you distinguish that?
Say again?
How would you distinguish
Well, if I was talking about testing wise or just when we see a patient? So Fragile X, so Down syndrome is going to be, they're going to have those facial features. So Down syndrome, they're not going to have that broad forehead, right? They're going to have that kind of flat face. They're going to have that low nose profile. They're going to have those epicampial folds. And with Fragile X, you're going to have a broad forehead. You're going to have a long face. But if I was to ask you a question on that, right? Then I have to give you some type of characteristics that make it clear that that's what I'm getting at. But in real life, though, you're going to really use those characteristics, what they look like, to actually make a diagnosis. All right, prenatal testing. So like I mentioned, there's a lot of things that we can't control for, right? But the ones that we can, we want to try. So we want to try to, like I already talked about in the beginning, we want prevention. When women come to you and they want that prenatal advice, make sure that they're good to go. Make sure they're updating their vaccines. Make sure if they're taking folic acid, if they're smoking, drinking, obviously tell them how harmful it is, tell them how it can actually cause damage to the baby's development, so make sure they're aware of that. Now, if a woman becomes pregnant, there are certain things that we can do to look for things that may be abnormal with that pregnancy. So every woman is going to get ultrasound. You're going to get ultrasound. We're not just trying to look for the sex of the baby, right? Even though that's a very common thing that we'll do. We're checking the ultrasound to make sure the baby's growing correctly, to make sure that they don't have any abnormalities that we can catch and potentially do something about, potentially, right? We also offer prenatal testing, prenatal blood testing to women, and that just kind of helps let a woman know that if she's at risk for having a child with any of these potential abnormalities. Now, if we see something on ultrasound, or if we see something with our blood testing, we can offer them something called chorionic villus biopsy or amniotic fluid analysis. I'll show you a picture here. So with this, with amniocentesis, what they'll do is that they'll take an ultrasound, they'll take a needle and use that ultrasound to kind of guide that needle into the amniotic fluid, and they'll take some of that amniotic fluid with the hopes of getting some fetal cells, because the fetal is, they have skin cells that are falling off, and by them taking that amniotic fluid, they're able to get some fetal cells and send that off to a lab to get tested for if we suspect that the child may have something, right? With chorionic villus sampling, what this does is that they'll take a piece of the placenta and send that off to to the lab to determine whether or not the child may have some type of abnormality, right? The difference between the two is that with chorionic villus sampling, you can do that a lot earlier. So if you want to know sooner, right, if that's going to help you plan, then you can offer that to patients, or OBGYN can offer that to patients a lot earlier than the amniocentesis. So the only difference there is this time frame. The risk of miscarriage is really low with both of them, but that's the main difference. One is you're trying to get an answer as soon as you can. The other one, you're comfortable with waiting, and so and it's a lot. They're both invasive, right? But it just gives you some time to maybe think about what you want to do based off the results that you get. Cool. Questions about any of that?